On behalf of the entire Young Ophthalmology Symposium team and the Council of Canadian Ophthalmology Residents, I'd like to welcome all of you to this year's COS session entitled Pursuing an Impactful and Stimulating Career in Ophthalmology. I'd like to start off by thanking the entire COS, Canadian Ophthalmological Society, for their help and support and once again hosting this session, specifically to Dr. Mona Dagher, the chair of the team, to Cheryl Ripley, the CPD director, as well as to Dr. Cedere Ziai, who acts as our board liaison on behalf of all young ophthalmologists on the COS board. We can go ahead right now and I'll move it to our second slide, and we have a couple of polling questions just to get things started. So if I could ask the team to pull up our polling questions. All right, so our first question is, very quickly, just choose your what describes you most accurately. Are you a medical student, are you a resident, fellow, staff physician, a guest? Give it just a couple of seconds there just to see what kind of group we have showing here. And probably a good amount of time here if we want to show what the results were. So we have a good proportion of both medical students, residents, some fellows, and staff physicians. So once again, welcome everyone. And our second question, we wanted to get a sense of where everyone's coming from, so we can pull up our second question. Where are you coming from, my friends? Give it just a couple more seconds there. And why don't we close that poll up now? So, as you would expect, we've got a good proportion from Ontario, but good presence from across the country. And we even have some international presence. So once again, everyone, please enjoy a warm welcome to this session for young ophthalmologists. We have a great and informative symposium ahead of us. I'd like to offer special thanks to Dr. Majid Mustafa, who's the Vice President of the Council of Canadian Ophthalmology Residents, for really taking the lead and pulling together this session. And from here, I'll introduce our speakers so we don't have to keep on coming back and forth. So first we have, needs no introduction, Dr. Ike Ahmed, who's the Division Head of Ophthalmology at Trillium Health Partners, as well as an Assistant Professor at the University of Toronto. He acts as the Fellowship Director for a Great Fellowship in Glaucoma and Advanced Anterior Segment Surgery at the University of Toronto. And he completed his residency at the University of Toronto and his fellowship at the John Moran Eye Center at the University of Utah. Dr. Ahmed will be speaking to us about what inspires him to innovate and how he goes about doing so. Second up, we'll have Dr. Zainab Khan, who's an assistant professor of ophthalmology at McGill University, as well as a clinical lecturer at the Université de Montréal. She has clinical appointments at the Jewish General Hospital, the McGill University Health Center, and l'Hôpital Maisonneuve-Rosemont. She completed her residency at Queen's University and her uveitis fellowship at the Université de Montréal. Dr. Khan will be speaking to us about tips for residents and fellows who are interested in academic ophthalmology. Third up, we have Dr. Josh Teichman, who's a cornea, complex anterior segment, and refractive surgeon at Prism Eye Institute, Trillium Health Partners, TLC, and the University of Toronto. He's currently a clinical lecturer as well as a cornea fellowship preceptor at the University of Toronto. He currently acts as the cornea section editor at the CJO, as well as acts as our kind of cataract go-to and organizer for the COS. He completed his ophthalmology residency at McMaster University and his cornea and external disease fellowship at the University of Ottawa. Dr. Teichman will be speaking to us about those difficult conversations about how to find a job in this day and age. Following Dr. Teichman, we'll have Dr. Cynthia Kean, who's an assistant professor and head of the electrophysiology laboratory and pediatric retina service at the Université de Montréal. She's a retinal surgeon at Saint-Justin, as well as l'Hôpital Maisonneuve-Rosemont. She completed her ophthalmology residency at the Université de Montréal, as well as her surgical retina fellowship at the Massachusetts Eye and Ear Infirmary at Harvard University, as well as a second fellowship in retinal degenerations at the Kellogg Eye Center at the University of Michigan. And finally, we'll have Dr. Steve Shandell, who's Dr. Keane will be speaking to us about how ophthalmologists can truly change the world as well. Dr. Shandell, as a clinical instructor at the University of British Columbia, he's a glaucoma eye surgeon at the Vancouver General Eye Care Center. He completed his residency at the University of British Columbia and his glaucoma fellowship at the Sydney Eye Hospital in Australia. Dr. Shandell will be speaking to us about considering fellowships in Australia. From there, we'll move into a quick Q&A session, and for that, I'll ask all attendees to please submit your questions. We will have some time to answer them just through the question and answer box below. With that, I'll turn it over to Dr. Ahmed.
Hey, thanks, Irfan. It's great to be with everybody here, especially knowing that this is the young yo ophthalmologist group that I realize I'm apparently not part of anymore. But I'm happy to share some thoughts, and it is an honor to speak about this topic. And I don't know if I'm really, qualified to speak about it, but I can share some thoughts and hopefully share some ideas for you all, both young and old. I know there's a couple of seniors on the circuit here, it looks like. And again, congrats to COS for what's been a really a great meeting. So I've titled this kind of the ground floor of innovation. For me, I like to stay close to the ground, and that's why I call it the ground floor. And these are all my consulting work that I do, which really was not my intention when I was at your stage as a resident. I had no clue about consulting or doing innovation or research or anything like that, and it kind of came a bit fortuitously. So, I mean, I know these are uncertain times. They're uncertain times in the best of times as a resident in terms of what your future is, what's going on, what the jobs are, where you're going to live. But certainly with COVID, it's even added more fuel to the fire, and it really, really is uncertain for so many of us. I love this quote to start off, thinking about these difficult times. And the pessimist complains about the wind, the optimist expects it to change, and the realist adjusts the sails. And so our job is to kind of get a perception and a feeling for where things are going and the winds of change and adjust those sails. And that's kind of the perception ability for all of us to do. Alain P's quote is great as well. The best way to predict the future is to invent it. And that puts you in the driver's seat. And that's really, I think, one of the benefits of being in the innovation space is really hopefully being able to be a designer of that future and the way we're going to be living. And certainly with COVID, I mean, what an opportunity to change and disrupt how we treat and how we assess and how we, go along in our careers. This is almost a reset for many of us as well. I wrote a little editorial a while ago or recently about innovation and how it's exposed the lack of development in healthcare. While the rest of the world has moved forward with technology, we've lagged behind around bureaucratic tape and other regulations. And I think this has basically been busted at the seams now. And really, it's an opportunity for us to just move forward and kickstart the whole process of innovation. So to me, now is an optimal time to innovate. So I know the title of my talk was, what inspires, or one of the objectives was what inspires one to innovate. It's a tough, difficult question because I don't know. I mean, for me, it's almost a natural thing to say, hey, I see something that we can do better. Let's try to change it. And I'll try to kind of maybe explain that a little bit. I think first part is just, having a purpose in life, and not to be too dramatic, but, just thinking about, where we're going and what our journey is about and how we perceive the world and interact with those around us, and what we take from it. And I think we are really all on a journey, and, we've all spent a lifetime learning scientific process, knowledge, clinical judgment. But if we really want to arm ourselves with the tools to change, we have to think about where we are in our journey, how you live your life, why you live your life, what you take from those around you, what you learn about yourself. And this is why I think the journey matters. And this is what I think really drives those that want to innovate, because we don't just go through the journey, on autopilot and just, think of a straight road. We want to make our journey count and make a difference in ourselves and our lives around and those around us. And it's not just about living on the edge. It's about really experiencing everything. It's about making, patterns from chaos and listening to other perspectives and incorporating them and questioning when no one else is, and thinking about things that are complicated and trying to simplify them. And that's, I think, what it's about. And I hope that we all want to drive forward. And I think that what we have within us, different knowledge, different expertise, but what we do have is a human spirit. And that's something that is always within the capability of every single one of us here to make a difference. And I hope that we push ourselves, because innovation really is driven by the human spirit. And really, I think innovation drives humanity forward. So think about those things. There's no doubt that we have to have the underpinning of scientific knowledge and know the details of the basics. These are critical and important. And we, of course, continue to try to work hard at our surgical skills in moving forward and developing. I wrote this out just talking about linear thinking, and a linear thinker does not do well in the innovation space. We're taught in medicine to kind of, see one, do one, teach one. This is how you do it, and we do it. And it works out well when we're learning at your stage right now. But when we're challenged or have problems or where things aren't working, critical analysis, deductive thinking, these are more critical, and lateral thinking are more critical than the classic way of teaching. And so the way to innovate and the way to progress is never straight. It's always crooked and prone to fail as well. We often want to be in a comfort level. And I think, the challenge with that, of course, is that when we're in this comfort level, the comfort zone, we're challenged to really push forward and to drive change because we're comfortable. And living in a constant state of discomfort and being uncomfortable, I think, is really where we can grow as people. And I think if that's one reason to innovate, I think that's something that I hope means something to all of us, because we have to feel like we're growing, we're moving forward, we're making a difference. As my previous mentor told me, I mean, to survive, you need to keep on moving, right? And stagnation and status quo means that we're falling behind. It may not mean something now, but in the future, certainly it may be, and we certainly see this in the current world as well. Like I said before, we have the human spirit, use it effectively. But one thing we have to always keep in mind when it comes to innovation and comes to making a difference, we have a lot of great people out there. I interact with a lot of great innovators and great minds in our field. But man, when ego gets in the way, it just destroys the very fabric of why we do things. Again, going back to the human spirit. So leave our egos at the door. I think the tools to be an innovator or to innovate starts with curiosity. And it's that thirst of knowledge and wanting to know and asking ourselves why, making no assumptions. These are mantras that I try to really push in our fellowship, in our residents, and really think beyond the obvious in front of us. Question everything, guys. We're taught not to question our faculty and question our preceptors, but you please should question. And in Johari's window, we know the different levels of truth and the unknowns. And what we think we know is the known knowns. What we think we know is wrong are the unknown knowns. That's a pretty dangerous place to be, assuming things that aren't right. We know things that we don't know. We question those things. And then there are things that we just don't know, the unknown unknowns. Let's also differentiate between innovation and research, right? Research is basically we're trying to answer a question, asking the right questions, solving a problem. Well, innovation is really about thinking differently. And so there are two very different aspects of how development occurs. This is a business model here. You put dollars in typically to build research programs to answer questions and gain knowledge. And with that knowledge, you learn how to think differently and apply that knowledge to make a difference. And that's the difference with it. This is a nice 9 rules of innovation from Greg Sattel, talking about the different ways that people innovate. Understand that innovation doesn't happen in one day or 1 year even. It takes time. It's a combination of multiple events. First, ask the right question. Remember, whether you're big or small in a single practice or an academic center, you can innovate and make a difference as well. We have to basically use all the capabilities that we have around us with an open mind and an open platform. Understand, of course, that innovation isn't just about new markets and new ideas. It's about making existing ideas better and, of course, using collaboration to our way. It's always helpful to be in the right place at the right time with the right people. Putting yourself in that position, of course, is always important. And ideas really are the basis of creation. So take the time to just sit and think and just come with ideas. But it's more than simply just making an idea. The actual process of doing something actually itself creates innovation, because ideas come to fore with the momentum and the inertia of doing this. Most of all, again, the ideas are around us and the concepts are in front of us to see, and the questions are there to ask. But we have to be able to set our antennas to receive, to be aware of those things, open our eyes and see those things that really make a difference. I think there's nothing wrong with being different. I actually think this is probably a positive thing, and all of us are different in our own way. Embrace it. Don't hide it, is what my advice would be here. Break the rules. Majid said to write questions on the Q&A, and I started writing on the chat network on our group on this Zoom call here. Break the rules when you need to, of course, but be mindful, of course, do it respectfully, hopefully, and don't piss too many people off. Finally, of course, there's a lot of attitude and courage and passion required in this. The biggest challenge is not the ideas necessarily, it's the apathy around those around you, or the skepticism around you that can potentially really slow things down and make it difficult in your careers. I don't think the innovators that I know, at least, are necessarily talented, but I do know they work hard. And that's something I think that really distinguishes those that are successful and those perhaps that aren't. We can't do it alone, and knowing those to collaborate, using mentors and partnerships, absolutely critical to innovate. Remember, know what your values are. we all have different values, and really use those values as your strength to guide us in terms of where you want to make a change. It doesn't have to be changing an entire medical field. It could be just changing the way you do things in your office or your patient pathway as well. Finally, it's about the journey, not the destination, right? It's about the people, not the outcome. And remember, of course, what we're most important and why we're here is to provide empathy and care of our patients. Thank you very much.
Right. Thank you so much, Dr. Ahmed. Certainly an inspiring and innovative talk. That might have been a bit too cheesy to say there. We'll introduce now our second speaker, Dr. Zainab Khan, who will introduce us to some tips and some interesting facts and thoughts about pursuing careers in academia. Here to Dr. Khan.
Okay, thank you so much to the COS and to everybody else for joining us. It's truly amazing what we're able to do now with technology. So today I'm going to be speaking to you about tips for residents and fellows who want to pursue a career in academia. Next slide, please. Perfect. So I have been in academic practice for a little shy of 2 years. So I'm going to try my best to share the tips and the pros that I have with all of you aspiring for academia. We unfortunately don't have a lot of great Canadian data on this, but we do have American data. A little less than 50% of US medical students actually aspire towards a career in academia, but in reality, it's only about 16% of students that end up pursuing a career in academic medicine. It's well recognized that most of the time these sorts of careers require fellowship training or graduate level degrees such as masters or PhDs. It goes without saying that these sorts of positions require obviously clinical care, some level of teaching and research as well. The first thing is to really determine whether or not academic medicine is a good fit for you. And once you've determined that yes, it is, it's important to then get prepared. And that's where my next 5 pros will come in. Next slide, please. Perfect. So the top 5 tips that I have to share with you today are: number 1, actively engage with your mentors. Number 2, familiarize yourselves with multiple academic environments. Number 3, take on academic activities early in your training. Number 4, train yourself to be flexible and patient. And number 5, don't wait for opportunities, go ahead and create them. Next slide, please. Perfect. So like I said, I've been in practice now for just a little shy of 2 years, and I can say that the number 1 piece of advice that I have for you is to surround yourself with mentors. Strong mentorship is really at the cornerstone of your success. And the interesting thing with mentors is that they don't necessarily need to be limited to your program, to your city, or even to your specialty. I know, for example, that I had mentors in residency that continue to be my mentors, but now I've moved away and I'm not physically present in the same department as them. The roles of mentors may change over time as well. One piece of advice I have for selecting a mentor or mentors is to draw on a specific quality that you see in someone that you want to emulate and develop in yourself, because it's really difficult to find a particular person who's going to be exactly what you want to become. And then finally, it's really important to distinguish between the concept of a mentor and a sponsor. And I'm going to get into that a bit more detail in subsequent slides, but a mentor is essentially somebody who's more senior and somebody who's going to advise you through their experience, unlike a sponsor who is somebody that will advocate for you actively in finding opportunities for you. Next slide, please. So number 2, familiarize yourself with multiple different academic environments. It kind of goes without saying that the environment you're going to feel the most comfortable in is the environment that you probably did your residency in. And probably by the end of residency, you're going to feel like that's sort of the way that things are supposed to be, and that's sort of the right way of doing things. But you'll find that there's a remarkable difference in methodologies and cultures from one academic center to another, even if those centers are within the same city or within the same province. And it's one of the easiest ways of familiarizing yourself with multiple academic environments is through fellowship. And so for myself, I did my fellowship in a completely different province. And in your own actual practice, it could be helpful to diversify your work experience by working in different academic centers, which is what I do. I work at both the University of Montreal and McGill. And in doing so, you're able to enrich your immediate work environment by sharing ideas from one place to the other. Next slide, please. So number 3 is to take on academic activities early in your training. So all of the 5 circles that I have posted here are, things that you're going to have to experience as a resident in the process of going through your residency. But my piece of advice to you would be to really engage in these exercises and in these experiences and use them as an opportunity to not just sort of get by, but to really grow in terms of your career. So when I was a resident, one of the best pieces of advice that I got from my program director, Stephanie Baxter at Queen's, was to create a teaching dossier. Now, this is not something that is ever really relevant as a resident, but when I applied for my first job at McGill, that was super impressive, and it really sets you apart when you have something that a lot of other people may not be offering. So use those opportunities and those exercises that you have to go through in residency, such as preparing grand rounds presentation, to really hone in your presentation skills, for example. Next slide. So number 4, train yourself to be flexible and patient. I think this is generally good life advice, but it's really, I think it rings true really for a career in academia. Everything in academia will take a little bit longer, and it's important to recognize that so that you're not frustrated with the process. And it's simply because, like government, there's red tape and a little bit of processes that have to happen, unlike in private practice. So things like your recruitment, that could take longer. Academic centers sometimes have a particular culture of how things are done, and so changing that culture could take a little bit longer as well. The other thing with academia is that it's an ever-changing environment, so you have to be prepared to fulfill new roles. And like we heard in the earlier talk by Ike, sometimes you need to embrace being pushed outside of your comfort zone. But if you can accept this, embrace it, and train yourself to enjoy it, you yourself will experience a tremendous amount of growth. Next slide, please. Finally, number 5, don't wait for opportunities, create them. And this is where the concept of sponsors comes in. So sponsors are basically colleagues that you can identify that are going to help advance your career by making you aware of different opportunities, whether they're promotional, leadership, speaking, etc. And so develop a network of sponsors that are going to help you in your career. If you see a problem, fix it, be creative, be innovative, and be collaborative in finding the solution. It's also important to be forthcoming about your goals and objectives. I think there's a certain level of wanting to say yes to everything when you're starting your career, because that's sort of the attitude that we're told is rewarded. But it's still really important for you to be clear and assertive about what your goals and objectives are, so that the appropriate opportunities are presented to you. And finally, I'm going to make a little note to the women in the crowd. In my graduating medical school class, about 50% of us were women, but still, I think the representation of women in academia, and definitely in leadership in academia, is a lot less than we saw in medical school. And so don't shy away from those opportunities. Academic medicine does need you. Next slide, please. So finally, just in summary, the 5 tips that I want to share with you guys are to actively engage with your mentors, to familiarize yourself with different academic environments, to take on academic activities early in your training, be flexible, be patient, and create your own opportunities. Thank you so much.
Thank you so much, Dr. Khan. That was super informative, really interesting. Quickly moving on and introduce Dr. Teichman now.
Hi, thank you very much. I'm just going to get this loaded up as well. And let's get. All right. Coming through okay? So my talk here is how to find a job. And, there's no real right answer. So let's try to see what we can do and see what we can talk about. These are my financial disclosures, none of which are relevant. So, what I really want to do is take you back and remember when the most important thing in your life was getting into medical school or matching to ophthalmology, passing the Royal College. That doesn't work so well this year, but it did all work out, right? All of these different big milestones were surpassed by you. And so we have to remember this is probably going to happen as well. When I thought about residency, I had this dream perception, and I think the reality was very different. And this is just me sleeping on the floor of an iRoom one night. So what makes you think this is going to be different? Now, I know that everyone does think that all of their staff had OR time immediately and that everything worked out perfectly for them. And the truth is, everyone thinks that this is the worst job market that it's ever been. But these are all misconceptions. You may be surprised to learn that many of your favorite staff did not have OR time immediately. Many of them also worried about getting OR time. And many of them will tell you this. They'll tell you this once you have OR time as well. So we have to re-examine these perceptions. So it's not a reality to walk into a perfect position. That is just not a new thing. People really have not walked into perfect positions ever, but we all do think they have. And people are concerned that if they don't walk into a great job immediately, they'll lose their skills. And that's not true. You'll get them back and then some. To be honest, right now, most of us haven't operated for 3 months, and I don't think most of us are too concerned. And there are new graduates every year, and that is true. There will be more graduates every year, and you have to be better than them. Now, don't complain that the people that have been out a couple of years have better chance of getting a job because you're new, and then complain in 2 years that the recent grads have a better chance of getting a job because you've been out 2 years, right? You always have to make the best of your situation, and you can't expect anything, and things do go in cycles. And in fact, I think currently there's going to be a slew of hirings coming up. So let's get to the meat of this, right? Now that we've examined that, how do I get a job? I don't think there's one correct answer. I think there's a number of routes to take, and we've actually already heard about some of those routes today. But there's the quote unquote research route, which ties in well to the quote unquote teaching or academic route. This is going to be a route for some people, that especially those that are keen on these things. There's the underserviced route, and I mean two things by this. I mean, one is underserviced areas, and two, I mean sort of, which is number 4, the missing service route. And that means finding a niche somewhere where they just don't have something and being that thing. But the truth is that all these routes start with very basics. And the basics are, honestly, almost everyone in ophthalmology is very smart and very teachable. It's very rare that anyone cares how smart you are, how high your OCAP scores are, or even how great a surgeon you are, if they can't stand working with you. If you are confrontational, if you can't be wrong, if you won't compromise, if you don't treat patients or other people appropriately, if you're lazy, if you don't answer your pager, no one's going to want to work with you. And everybody here listening knows this. This is something you all know, but it does, you have to say it. That the basics are, we expect you to be smart. The question is, can we work with you? So be a team player. The trading on call shifts is one thing that, in the future you may need to do. And when we see people that are very, very easygoing and easy to trade an on-call shift with, we know that that's sort of a team player. When people are very regimented and never trade on-call shifts, they make it difficult for everyone else. Seeing the last patient. So when there's one chart left and everyone's sort of looking for the afternoon to start, grab that chart. You'll all get out sooner, but more importantly, you'll learn more than everyone else. Be friendly, work hard. Don't ever, ever, ever throw your co-residents under the bus. This never looks good. And getting back to what I was saying, knowledge is expected. Knowledge just gets you in the door. We all assume the knowledge. So, I mean, how did I get a job? One of the things I did, like I said, I hit every route, but one of them was I tried to be the absolute best resident I could be. This is confidential, so please don't share, but these are things that I did during my residency. And I think that these things, and fellowship, and I think that these things are important, but they're not the most important thing. So as I mentioned, I took every path. I took the research route, I took the academic route, I took the clinical or underserviced route, and I also think that, I'm going to say I took the personality route. So for research, I completed a research fellowship. I don't expect everyone to, but that's one thing. I completed a master's of public health during residency. Again, I don't think everyone should do that. I don't even think a minority of people should do that, but I think that if you want to be an academic, you have to have academic degrees, and that's expected. So, everyone's going to have, if they are interested in the research route, you're going to have a different way. But I do think that you do have to build your CV. So a research fellowship, a master's, I did a clinical fellowship, and then of course, present, publish, speak. And this is still going on. This is still going on today. For the academic or teaching route, you know, one of the things I did is I joined the faculty when I graduated. At first, I had twice as many learners, and by that I mean medical students, undergraduate medical students, than anyone else in our program. I never said no to a learner, and then you know, starting off pretty much right after my fellowship, I joined on to, you know, COS to do different things. So those don't apply so much in residency, but they are, you know, they are things that you can do as a resident that will help you with the teaching and academic route. For the clinical or underserviced route, rather, you know, I think you got to find something. You can't expect that a hospital that's established is just looking for someone else. They haven't been operating with one less person this whole time waiting for you to graduate, right? Like, they're clearly at the appropriate number they need. So you have to find out what would actually benefit them. What don't they have? And you know, I think Ike said it best when he said, do the cases no one else will do. And he states that this is one of the reasons that he's done as well as he has, which is probably true. So personality. I mean, I'm not going to say I am, but I'm going to hope that people think that I'm hardworking, that I'm well liked, that I communicate well, that I'm a team player. And I hope you know, that people will vouch for me. I still get, you know, joking aside, on May 29th, someone asked me about a potential job. Like, I still get people asking me, and I think it's because I've done all the things that I'm suggesting. And lastly, despite what you might read in the chat box, my job was no accident. I mean, I spent 6 or 7 years building towards it, and now, since I've had it, the last 5 years really improving it. You know, so I still, even after all that, didn't walk into a perfect situation. So I started as a locum, and I did that for a few months and left. At that locum, I had no clinic time. So I basically would take my on-calls, and then the next day I'd go to the hospital and see on-call patients. And then I would do a few OR days here and there. And that obviously wasn't great. So I started working in another clinic, and then another job offer came in. And that job offer was 2 OR days a month of cornea and full-time on-call, of course, and nothing else. There was no cornea program when I showed up, and we spent months building it. Every single question was a literature review. I had no cataract time whatsoever, and I would fill my cornea lists with minor procedures after the number of transplants I had were done. Time went on, and you know, the cataract numbers were under what they needed to be. They needed some help, so they gave me literally 2 OR days to do cataracts. After I did that, I was lucky, and they gave me a day a month of cataract time. I gave a very similar talk to this in 2016. And I said, this is my current schedule in 2016. And it was, you know, I had the cornea days, and I had 1 day a month of cataract at that time, and a minor day and a refractive day, and mostly clinic other than that. And so now I'd like to show you that even in the last 4 years, my schedule has changed. And since then, now we're doing, even though we're doing the same number of transplant days, we're doing twice as many transplants per day. So it's just transplants the whole day, usually 4 or 5, complex IOL work after that. We were doing 2 days a month of up to 30 cataracts a day. So I got full-time cataract time, and then added on cross-linking from at KEI, and then continuing the cross-linking at a refractive center. So even still, my schedule kept getting better and changing. And you know, today my schedule is a little bit different. It's mostly this, but prior to, say, 3 months ago, my schedule was very different than 4 years ago, even, because you don't walk into a perfect job. So my final sort of thoughts are, you know, I know people are going to be concerned and worried, but the first thing I want to say is it almost always works out. There are very few good graduates who do not have OR time a couple of years out after residency. There really are very, very, very few. You have to be flexible though. And so, you know, your dream job and your dream location might be difficult. You might need to compromise a little bit, and you have to decide what matters to you. Some people will really want to be around family or a spouse. Other people are going to want to be, you know, the subspecialist, and you can only do that certain places. So if you're if you're willing to wait, you know, you'll have to figure out where you want to be. And this is really just saying what I was saying before, that, you know, you might have to make some compromises. During the initial time in your career after residency, I mean, you got to be the best you can be, the best junior staff, and you find a niche. So like I said, I hear they need X and Y, low vision in Queens. I mean, we're at whatever it is, you can make a niche for yourself. Be helpful and make an asset, make yourself an asset. Enjoy the stage. You know, like I said, at every stage, you probably had some stress that you weren't going to get what you wanted. And the truth is, it almost always worked out. It's worked out for pretty much everyone here if you're here. So enjoy it, be patient, see the patients, prescribe glasses that I'm joking about, hone your skills. You'll actually make a little money right now, which is nice. And so my sort of final words are, you make your own luck. You know, people aren't lucky. The truth is, most of the people that you think are lucky are well liked and have done the right things. Be the best at whatever it is, at whatever stage you're at. Be positive, keep a positive mindset, be well liked. You know, yes, you need to know a thing or two about ophthalmology, of course, but I think that there's a lot more than getting the top mark on the OCAPs. Be patient, be flexible, expect to build up or ramp up. Don't expect to walk into a perfect situation. No one had anything handed to them, and good things will happen. And I really cannot stress this enough. So thank you very much.
Thanks, Dr. Teichman, for that motivating and empowering presentation. I think it does give a lot of us some reassurance, especially those of us that are heading into kind of the final ending of our training. So really appreciate it. Next up, I'll introduce Dr. Cynthia Kian. Handing it over to you.
Okay, great. Perfect. So I want to start off as my co-panelist to thank our friend Majid for inviting me to this session. This was a very fun talk to prepare for, but also I think challenging to organize because it's a very ambitious topic in under 10 minutes. So I hope to generate some thoughts for a conversation, discussion, because these are just some of the thoughts I have about it. So let's dig in. Right. Great. So we can really look way back in history, but in terms of talking about impact in ophthalmology, the field truly specialized in the late 19th to 20th century. And I've listed here some of the landmark figures in our field who have made sight-saving care and surgeries accessible and available worldwide, and who have really revolutionized how we practice ophthalmology today. And I think it's important to recognize that the world around us today is very different from back then, and hence the way we will make an impact today will also be different from back then. More recently, I'm sure we're all familiar with the annual power list that the journal The Ophthalmologist puts out. And this is the latest version from this year, which shows the changing faces of influence in ophthalmology. And as you can see, it regroups ophthalmologists who are not only clinicians, educators, innovators, and researchers, but also influential thinkers, thought leaders, opinion shapers at the same time. And I have to say, as Canadian ophthalmologists, we're proud to say that Dr. Ike Ahmed's contribution figures very prominently. Many of these people hold several hats at once, pun intended. And it's too unfortunate the picture here cuts off the nice Mickey Mouse Wizard of Surgery hat on Ike's head. But these are all great models and examples who are at the peak of their career that we as young ophthalmologists should aspire to. Interestingly, we see that this journey towards making an impact in the world starts early on. And the same journal puts out every few years a list of rising stars in ophthalmology as well. And I'm sure you may recognize many of these faces as these are some of our peers or some of your peers. And one way of finding your direction or interest is also to look at some of what they have been engaging in order to get inspired. So I've tabulated some demographic information as well as these rising stars' spheres of influence. And first of all, it's encouraging to see that gradually more women ophthalmologists are on this list than previously. On this list, we see that about a quarter, 26%, are women. And research and posterior segment dominate the fields of excellence and of specialties involved respectively. So it's really interesting to see what's up and coming and shaping the world of ophthalmology, and to see that the purely academic contributions are now sharing the platform with those working with industry, working in the nonprofit sector, working on innovation. And also social media is also now a totally new platform and category that has been listed in these directions. Of note, of all these rising stars, we see that only 8% are double MD PhDs. And actually 3 of the recipients received the recognition while they were still residents and fellows. As we all know, in the current background of COVID, ophthalmologists are more than just eye doctors. Many are working on the front lines, and many have made the ultimate sacrifice for their selfless work, and none more so than Dr. Li Benliang, whom we all know now as the ophthalmologist and the first public whistleblower who signaled the appearance of COVID-19. And as the AAO editorial stated, Dr. Li's work should not be judged by the number of peer-reviewed articles or the amount of competitive grant funding he received, but his astute recognition of COVID and his heroic attempts to warn colleagues should really be recognized by all. So here are themes to focus on for up-and-coming ophthalmologists in the years to come. I think there are no predefined pathways towards impact, which, as you know, by the way, is not the same as either success or fame. And there's widespread acknowledgement that the medical professionals of today now require a much broader skill set than just clinical knowledge and expertise in order to succeed. And general societal responsibility within the world, wider than just ophthalmology, is the norm. So we have to look beyond ophthalmology and ask ourselves, what do we want to accomplish? And it's important to reflect on your role and your interests early on and work towards it. But since it's a journey, I think it's totally normal to have a more crystallization or a change of our goals as we go along. And the areas I think that are going to influence and impact ophthalmology in the future include the role of social media and the internet in medicine, the advancement of AI, which has shown early promise in many fields of ophthalmology. It's going to involve institutional, higher level healthcare reforms in the domain, networking with other physicians, and also the global connectivity in medicine. So briefly, I want to share 6 advice tips to consider for fulfilling an impactful career in ophthalmology and medicine. And many of these have already been presented very nicely by some of my esteemed co-panelists today. So tip number 1, you may want to be like Ike. As we can see, most of those making long-standing impacts are still doing so in the context of academic excellence towards new discoveries and therapies in medicine. You may want to be like Dr. Teichmann, as he has demonstrated a common theme in success is gaining further knowledge by either pursuing fellowships or pursuing further degrees to help achieve effective leadership in different roles. So be that in formal training, that's definitely not necessary, but it might be helpful in providing foundational knowledge and tools that are formally taught in other spheres, such as business, administration, health policy, which are all required for effective leadership. You want to find leadership roles. So as Dr. Krani and Dr. Mustafa have demonstrated, clinicians who participate in leadership development also lead by example, and in general are more likely to feel empowered to influence the provision of patient-centered care, develop a greater self-awareness and confidence to initiate positive change around them. And I also want to stress the importance of cross-talking with other fields outside of ophthalmology. As you can see here, I'm participating in the event of the Young Physician Leader Meeting at the World Health Summit 2 years ago. And I think having dialogue outside of the field, as you know, can widen our perspective and bring about more global coordinated reforms. Find a mentor. So I'm not going to delve into the details as Dr. Khan's presentation excellently already illustrated the point. She's too modest to mention it herself, but she was voted best teacher by the residents last year and is an excellent mentor herself. And I think, as she said, no one mentor is perfectly adapted to your needs. So you may want to find several or be inspired by different aspects of their practice, and the people who are your mentors may change over time, and they can also be near or far. You've got to be ready to adapt to change, be flexible to your environment. As we'll hear from Dr. Shandell just after this, you have to be ready to move, whether it's to go for fellowship, to start off that cataract camp in Nepal or in the Amazon forest that you've always dreamt of, or when an unexpected opportunity arises. It's never too late, but I think as a young ophthalmologist, this is a particularly good time early in your career when ties and are still fluid and things are flexible. the average person today may change careers and career locations up to 5 to 7 times during their working life. And I think medicine is no exception in this new reality. And finally, tip number 6, you want to pay it forward. So it's never too early to want to start mentoring others, as our senior resident leaders here, Dr. Wilcaminel and Dr. Giziato and Short, demonstrate in their everyday life. And some of my closest colleagues and friends today were juniors that I've mentored, and I've learned so much from them and from our interaction, and find it extremely beneficial for the development on both sides of both individuals. Also, you can make an impact in fields completely outside of medicine, as there are many talented, multi-talented polymath ophthalmologists out there, such as the authors Robin Cook and Dr. Conan Doyle, who both have influenced generations with their writing. And as we'll see later, Dr. Tina Falfelli has already made a mark in this domain. And as we see here, she is signing autographs for her handbook, Guide to Clinical Ophthalmology. And finally, social media is also growing very large, not only in medicine, but also in ophthalmology. And here are just some of the influencers I follow. Oh, baby, when you talk like that, you make it wanna go. So be wise and keep on reading the signs of my process. Baby, when you talk like that. I'm good. So perhaps you will be the next great social influencer of ophthalmology, or maybe you already are. So if you are, just share your handle on the chat box or add any other recommendations to this list. But as you can see, you can either be comedic in your delivery, or you can do the standard TikTok dance. This is a platform that can reach more and more people. And as lighthearted as it may seem, I think there is a potential deep impact that can be made, because you have this platform which can simplify important medical messages, disseminate true medical facts, and dispel myth. So in conclusion, the theme here is young ophthalmologists are trying to change the world for the better in a changing world. And some basic tenets still stand despite those challenges, which include practicing the specialty we love, saving sight, improving lives, improving healthcare systems, be inspired by the positive role models who are all over and all around us, and create your own path while getting inspired to do something that's purely inspirational to you and that impassions you, and hopefully make a positive impact both locally and on a wider scale. Thank you.
Thank you so much, Dr. King. That was amazing. We really appreciated your thoughts there. I'll move on to the last part of our first section of our symposium. So I'll hand it over to Dr. Steve Schindel.
Hi there. Well, thanks so much for having me. And today I'm going to talk to you a bit about fellowship in Australia. And I think, just hearing these wonderful talks from our previous speakers, it's really made me realize, reflect a lot on my own experience. And I think Cynthia's right. I think sometimes things happen that we don't necessarily anticipate, but we have to be brave enough and flexible enough to accept them and roll with them. And I think I'll start with my polling question now. If we could put up the polling question, please. So I want to ask the audience, what factors are most important to you in selecting a fellowship program? Is it the quality content of the program that's paramount regardless of where you go? Is it a mixture of the site and the training with an emphasis more on the training? Is it the training but with more of an emphasis on the location? Or finally, is it just important where you go? And that could be because of family reasons. I don't think there has to be stigma with that, where the actual program might be secondary. So perhaps just we'll take a moment to look at that. And then if I could get those results, please. Great. So yeah, I think, there's some flexibility I think that we recognize is important in this case. So I'm just going to go over my disclosures. These are the ones that are relevant, not to this talk, but generally what I've done. This is the poll question we had. So we can bring down the poll question, please. And when when we want to consider doing fellowship in Australia, I think generally we need to think a little bit about selecting a fellowship and what goes into that. I'll talk briefly about training sites in Australia and the culture there. We can talk about work culture specifically, but also funding opportunities. I won't spend too much on the visa application, and a little bit about leisure opportunities in Australia. You know, we can't forget that this is an opportunity to go abroad. It's a year of our life, and you really have to make the most of it. It's not just about work. So how are we picking a program for fellowship? And I think, you know, it's not always straightforward. And I think in the past, I think a lot of Canadians look to go to the US. I think it's, you know, it's a nation with 10 times our size. They have tremendous training programs and leaders, and it's in close proximity for many of us. So I think for a long time, you know, we've recognized that as sort of a beacon for training, but I wonder if that's just beginning to switch a little bit now. Certainly the visa process has become more convoluted. Perhaps, you know, there's some questions. Is it a little bit more challenging and a little bit less welcoming, not necessarily from the institutions, but, you know, perhaps from getting a visa, you know, and that's made me wonder a little bit about what the trends are going to be as we go ahead in fellowship training. Certainly, I'm involved with our glaucoma fellowship training in Vancouver, and we've seen a lot more interest in our residents staying in Canada, and a lot more inquiries from other trainees within Canada. And I think there's tremendous training opportunities here. So I think that's one of the trends we're going to see as there continue to be some challenges accessing the US, and perhaps some thoughts about where the best training might be. You know, another place that we see frequently is individuals looking to go to the UK. And this was something I explored with some elective time. I had, you know, that was in 2011, I had a chance to go to Nottingham and Moorfields, and I was strongly considering, you know, doing some fellowship training there. So another site that many are considering now in these uncertain times. So is it as simple as good training, good place to live? I don't think it's quite that simple. I think a lot of times we look to meet a boss, you know, at a meeting, or a potential supervisor at a meeting, and get a sense for what the program might be like. We might try to organize a site visit at a place to get a sense for what it's like. You know, just to understand a little bit more about what we're getting into. But what do you do if that's not just an hour away? It's not like going, you know, certainly when I went to visit Toronto, I shot over to Queens and Hamilton when I was applying for CARMS. But what do you do when it's halfway across the planet? How do you learn about those opportunities and what's out there? Well, I mean, I think you need to have trusted sources of information about these programs you choose. And I think, what are we looking for in an unknown year, a fellowship year? We're looking for a little bit of control. So many things when we're a trainee are out of our control. We're looking for opportunities, you know, to just have a little sphere of something that we have some say over. And I think, you know, one of the points of this talk will be reach out, you know, to myself, but others, if you're looking at going to some of these places that are far away and you're not sure what to expect. You know, I trained at University of British Columbia in Vancouver, and we've always had a strong relationship with Australia because we're just across the pond from them. And we've always had lots of fellows that come over for a year. And those people became tremendous contacts for me when I was really starting to consider where I might go, because you know, we didn't have a lot of people ahead of me. Certainly nobody had done glaucoma at Sydney Eye, where I had gone, you know, in the past ever. So it was important to kind of reach out to those people who might be able to tell us a little bit about what to expect. So there's a lot of unknowns when you start fellowship, but embrace those and don't be scared of those. When we look at Australia, you know, most of the training programs are based out of Sydney, Melbourne, Adelaide, and Brisbane. I didn't include New Zealand, but they're under the same accreditation organization, which is called RANSCO. So those sites would certainly be included in the same registration bucket. And they have some wonderful training centers in New Zealand as well. And when we look at work culture, you know, I worked again at Sydney Eye Hospital, which was a busy tertiary center right in downtown Sydney, about a couple blocks from the Opera House. We're looking at a dual public-private system there, where all patients have medical care. So there's it's a bit like Canada, everybody's entitled to their health care, and there's a spectrum of what we might see. There's patients that are fully public. There's patients who you've never met before. They're seeing your staff consultant privately, but then they come to public surgery because they can't afford private surgery. And then there's patients you don't interact with except perhaps unless your boss asks you to, and those are fully private patients. Now, there's a rule in Australia: everybody's entitled to public care, except you don't get to pick your doctor unless you're willing to pay. And I quite like that rule. I think it's something we should, that I think would work in Canada as well. But everybody's entitled to care, but you're not entitled to pick who cares for you. You're entitled to high quality care. And so the fellow, really works in the public system, but you might be assisting with private surgeries, but you're really the quarterback for the public system at your institution. With regards to clinic and OR, the consultants usually have a half, 1 or 2 days, usually max, at the public hospital, and their OR time is usually 50% of their clinic time, and they're salaried for their public time, and then the rest of the time they're fee for service in their private clinics and private ORs. And so really you've got quite a large cohort of consultants that are covering a particular hospital. And so it's really quite a big team you get to work with, and you get to learn with lots of different people. Now, if you're doing something more obscure like Orbit, where there isn't going to be as many specialists, obviously that team will be much smaller. But for things like glaucoma, cornea, retina, it's a big team. And you're, like I said, you're the link for the public system. You're the one who's going to carry things from one doctor's clinic till their clinic the next week. And really, patients are encouraged to stay within their most responsible physician's clinic rather than bringing them back every day. And you've got lots of help in the form of excellent Australian registrars, which is equivalent to our residents, who rotate through the blocks for varying lengths of time. So, it's a hard-working place, and sometimes you feel like you're going to get gobbled up by a hungry croc. But really, the specific demands are going to really depend on your subspecialty. The retina people were there all the time, cornea a lot, us a reasonable amount. So, you're going to be busy. There's a lot of inpatients in Australia, and these patients need to be seen every morning if they're admitted for surgery or after surgery. But fortunately, you have the assistance of the junior trainees to help with that. And, the clinics start a little bit later than was my experience in Canada. They're a little bit starting around 9 and running till 5:30. Volume of surgery was no issue. I easily did a couple hundred surgeries there. And, really with the public system, sometimes there's volume to get through. So there was opportunities to do unsupervised cataracts when you were there. They said, listen, we need somebody to go and do some extra cases. Are you willing to do that? Now, if you're not comfortable doing that, you don't need to do that. But I loved it. I loved the opportunity to go and do things on my own. And then when I came back and got a job in Vancouver, I felt very comfortable being on my own and operating on my own. I also operated on my own and supervised trainees. So I thought that was a wonderful opportunity. So there weren't any issues with volume. And I do think that holds true across Australia. Funding will vary based on your site, but at Sydney Eye, there's a hospital foundation of almost $50K a year, which isn't much. Australia is expensive, but there's a Royal College Detweiler fellowships you can apply for and they're competitive, but certainly could add extra funding. But there's private surgery you can assist with. Now, you don't necessarily have to, or you might have to, depending on your job, but that's an opportunity to earn extra money. So that's really going to depend on your fellowship. I sought some of those out to make some extra money, and I was able to do that and earn maybe another extra 20, 25 grand, which was nice just for weekends and holidays and things like that. But you're gonna have to pay taxes for that at the end. Their tax year does not coincide with ours. So you'll get a reasonable tax bill when you're back working. So that should help ease the pain. I won't get into huge details about the visa application. It's not as complex as the American visa system, but it takes time. You need 6 months. So don't sign on to an Australian fellowship saying, oh, yeah, I'll be there in a month or two. It's going to take about 6 months, and it's cumbersome but manageable. So just keep that in mind, and the organization should help you through how to do that. Let's not forget leisure. You should make sure wherever you are, make sure you have time to explore. I mean, if you're going to the other side of the world, this is a wonderful opportunity. Yes, you're going to be busy, but even my colleagues that did retina, in Australia had time to explore and see that lovely part of the world, because there's so many good things to see. So some of the travel can be with meetings. I went and presented in Singapore, Tokyo, and in Hobart, Tasmania as a fellow. So that's an opportunity. And then also took holiday time in Darwin at the Reef and in New Zealand as well. So, and then, Melbourne several times. So lots of opportunities to go and see things and soak up the local culture. So, what I'd say is, go confidently into the unknown and the path becomes clearer. I think that's absolutely true. There's going to be discomfort. Things are going to be unknown. Thrive with that, unknown. Embrace it. That's part of how you grow as a person. So I think, take that in. And I'll just leave on this note, Australia alumni, These are the ones I could think of off the top of my head. I don't mean to forget anybody. If I forgot anybody, I'm sorry, but reach out to people who have gone, take a picture of that slide and reach out to others you've known that have gone and ask them for connections and tips, because that's how things get done. And that's how people halfway around the world get these fellowships. Thank you so much. Send me an email if you have any questions.
Thank you so much, Dr. Sandel. That was very informative. We have a few minutes for questions, about 3 to 4 minutes. Question for you, Ike, if you're still around, from Dr. Yin. Can you comment on how you manage to do all that you do with clinical work and research and balancing family life?
Well, I don't know if balance is really a word in my vocabulary. You're always kind of struggling to kind of make everything work out. I think over the years, surrounding yourself with good people really help. Delegating tasks, delegating work is important. And you try to keep yourself at a certain level where, you can keep your head up and keep a perspective. I've been, again, fortunate in my professional life to have great people to work with. Josh Teitman, one of the folks that's in our group. And Josh, you're not leaving despite all the job offers. And just having, really good people to work with that kind of, add momentum. It's so much better to work in a group and do things together. And help to relieve each other when things get busy. So I don't know. I think time management is always important. I would add to that, right? I mean, everybody talks about this. Sleep is a bit overrated. You only need about 4 or 5 hours of sleep. That should be enough. And the rest of your time, use it effectively. Wake up in the morning at 4:30 in the morning and spend those 2 hours effectively. Your probably efficiency at doing work at 4:30 to 6 in the morning is going to be much greater than any other time of the day. So it's about doing things efficiently. And saving time in that matter. That's what I would say, but by no means am I an expert of it. And I'm sure everyone in my life would tell you that I'm not balanced.
Thank you so much for the honest answer. So we have one more question, interesting question. For all the panelists, what is your advice for trainees who want to embrace their quirks, differences when starting out, but feel the pressure to conform, especially in the world of medicine where conformity is not only encouraged, but in many ways mandated?
I feel like Ike should answer this one.
No, I should answer that last. I mean, you guys have some. I mean, we had, by the way, great talks from everybody. I mean, fantastic from everybody. Zainab, Cynthia, Steve, even Josh gave a good talk. But yeah, it's a great question, Majid. Let's hear from others.
Dr. Khan, Dr. Kian.
So I'll say one thing. I think it's the drive to want to do things differently and not conform is admirable and it's good. I think it's important to balance that though, especially when you're starting out and you're a junior staff with some gentleness. Change doesn't always come easy. Sometimes institutions and places have deep cultures and ways of doing things, and so it's important to tread that path carefully and balance. Know the appropriate opportunities to introduce change rather than sort of coming out of nowhere and trying to change everything. That usually doesn't go so well. So that would be my advice.
Yeah, I would agree. I would echo what Zainab has said. I think part of it also is the journey from trainee to attending. I think a lot of it is, I think a lot of things about myself I didn't know when I was a trainee. So I think it's normal to have a structure of what conformity is and kind of grow little by little. I feel like some of my quirks maybe I didn't know were were personal quirks. I thought maybe there were, it's normal to also question oneself, like, is it at this stage, is it normal that I feel or think this way? And you're trying to, I think, learn and mature as a clinician at the same time as discovering, which parts of your personality are sort of maturing into itself. So I think, part of it is it's normal. You want to introduce small parts of your, of those quirks little by little, but as you advance also and you come to a position where you can sort of change the environment or set the environment around you in a certain way, then I think you can, once you know yourself better and better, you can establish some of those things as things that work for you or perhaps are different from how others are doing.
Yeah, I think those are great points, Cynthia. I think, you want to be true to yourself. I think there's a way to be confident in who you are, but by still being respectful though to everybody else. And I think that's what people look for. Nobody's looking for, total conformist. I don't think those sorts of people, you have to worry that you might not seem genuine then. I mean, we're all different people and we need to embrace that. But I think it's come up from every speaker. It's being respectful of the people around you, listening to opinions. I think, and looking to build consensus. That's certainly what we look for at our program if we're looking to add people. And I think, there's nothing wrong with having differing opinions. It's that healthy conflict that grows a department and grows a group. So you need that. And like, I get worried when people always agree with what I say. I don't think that's a way, those aren't the team members I think that are helpful to have looking ahead. It's that healthy friction that grows a group done in a respectful manner.
It's a good point. I think at the level as a resident, I'm going to recommend something. Don't be a nonconformist. Don't do that, because no matter what, as Josh said, people want to hire people that are like them. In most cases, I hate to say that. The true leader will hire somebody who's not like them because they want to bring something new to the program. The reality is people want to hire people like who we are, and that's the reason why we are privileged in many ways. And so I hate to say this, but you can be your own self inside, but outside you have to be a certain way, conform a certain way. This is society, guys. I hate to say that. Unless you're willing to take that and basically lose an opportunity. If you come across as being a bit of a shit disturber or rebellious, you may lose an opportunity. Take it from me. I mean, I didn't get an academic job. I got a job out in the boonies where they didn't know me. So I mean, that's something to really be careful with. I would just say, I'm just being honest about that. But when you get your job and then you have your time to build up, and as Zainab said, do it slowly, then you have an opportunity to perhaps make that change. But you can still be who you are inside. It doesn't mean you have to actually show it out right away.
I mean, I think the other point I'd make is, like, I hear from a lot of people, they say, well, there was this job, it looked pretty good, but I didn't go for it. It's not really what I'm looking for. And I can think of definitely some people that have made jobs into what they want. They've taken them, they've wanted to teach, they've wanted an academic position, and then Ike obviously is a major example of that, but even people beyond that who have taken community jobs and then now they're major learning sites for our program. So, don't be worried that the job isn't exactly what you imagine. Build the job, be part of the change. And that'll happen slowly. Josh alluded to that too, but I mean, anything worth having wasn't built right away. It takes time.
Thank you to all the panelists. In the interest of time, we'll move on to, I'll ask everybody to stay on because we might have a second Q&A, depending if time allows. There's a lot of interesting questions coming up. So we'll move on to Andre and Matt. So we have Dr. Andre Zigiato, who is a PGY3 at the University of Montreal, and Dr. Matthew Balakamanel, and I'm very proud to pronounce his name properly. And they're going to be presenting the COVID resident survey results. Much awaited.
All right, hi guys. Can you guys see and hear me okay? Anyway.
Yeah, we can see you and hear you.
Thanks, Majd. It's going to be a hard act to follow, but we'll do my best to be entertaining. I'll get the ball rolling, and Matt will finish us off. Thanks for the opportunity to present the results of the Canadian Ophthalmology Resident Survey in 2020. We conducted a peer-reviewed survey that was modified from a study published by Tran et al. In 2018 on resident wellness. And because of the recent events with the pandemic, we added some more questions about COVID as well. It was compiled using Google Forms and emailed to every ophthalmology resident in Canada, total of 217 residents. And we emailed this out between May 6th to June 13th. We had a pretty good turnout. 102 residents responded with a total response rate of 47%. As you can see, the top responders were from University of Montreal, UBC, McGill, and Western. And as you may know, there is some prize money to be won. The COS graciously donated $500 to be given towards resident wellness. And if programs had more than 70% response rate, they could have been entered in the draw. And these four programs, University of Montreal, UBC, Western, and University of Manitoba, made the cut. So we'll see at the end here, we'll have our draw, and we'll see who wins the big money. All right, so in the survey, we had equal representation from all years of residency, same thing with gender. We seem to have slightly more respondents from larger programs with greater than 20 residents. So let's talk about the first half, COVID-19. What was the resident experience like? Firstly, 93% of residents felt they had adequate PPE to see patients. Only 67% of residents said that all patients in their clinics were wearing masks. And only 26% of residents said that they had an outbreak of COVID in their departments. As of early June, the majority of residents had returned to their scheduled rotations at reduced volumes, whereas 30% were still doing emergency care only, working in shifts. Again, this might have changed over the past month. There were 31% of residents that said they were tested for COVID. And out of this 30%, 3% tested positive. And only 20% of residents have examined a patient that was confirmed positive for COVID. 5% of residents were assigned to work in a COVID unit. And of these 5%, some worked a week, but some worked greater than a month. When examining asymptomatic patients, the PPE used varied amongst residents, but the majority seemed to prefer gloves, eye protection, and a mask. When it came to asymptomatic patients, we prefer to gown up, glove, and goggles, but there seems to be a split between using masks or N95s. It was really right down the middle. Surgical residents on surgical rotations, the majority of them in early June were not operating. So what about attitudes? How do residents feel? How has COVID impacted them? First of all, the majority of residents were worried about catching the virus, more than 50%. However, a larger proportion were worried about spreading it to their patients, and even more, almost the vast majority were worried about spreading it to their family and friends. And this could be echoed pretty much across other disciplines as well, most likely. The majority of residents did feel more isolated due to social distancing measures, and over 70% said that their anxiety increased compared to before the pandemic. Residents were less worried about their clinical skills deteriorating, but they were worried about their surgical skills deteriorating, and senior residents were quite worried about finding jobs and fellowships. Residents were not as concerned that they had to repeat rotations, and really were unsure across the board whether or not this will really improve to normal by the end of summer. However, as a positive note, the majority of residents still feel that they'll have sufficient training to become competent ophthalmologists by the end of the residency programs. In terms of coping strategies, it looks like the majority of coping strategies were fairly positive, like speaking regularly with family and close friends, cooking, exercising, spending time outside. A couple of more negative coping strategies, such as increasing substance use, but for the majority, it was positive. In terms of keeping up clinical skills, residents read their manuals, saw patients in clinic, and attended a plethora of very high-quality webinars. However, very importantly, 51% of residents said that they did not have access to either a surgical simulator, practicing in the wet lab, or cases in the OR in order to keep up their surgical skills. So just as a take-home point, 1% of the residents that responded to the survey were confirmed to be COVID positive. This whole pandemic caused increased anxiety, and it seemed to affect senior residents the most because of reductions in OR time and because of job and fellowship stress. And to kind of add on to the surgical point, the majority of residents stated we did not have access to wet labs or simulators. So we definitely need to make this a priority in the coming months to address this, to improve surgical skills outside the OR. And thankfully, there's a general positivity and there's a good outlook towards the future of our training. So I'll hand this over to Matt now.
Thanks, Andre. So I'll be talking about general resident wellness, which was the other part of our survey. So our first question was on access to free counseling and behavioral health services. So 65% of residents said that they had access to these services. And of those who did have access, only about 73% actually knew how to access these services. In regards to emphasis that programs put on a culture of resident wellness, 55% felt that there was a moderate emphasis, whereas 35% said there was minimal and 5% said there was actually no emphasis whatsoever. In regards to obstacles to addressing residency wellness in the program, most felt that there was a lack of time to attend wellness programming, whereas a lot of people felt that there was lack of wellness programming to begin with. In regards to situations that lead to or cause stress or decrease wellness in a program, some of the highlights were academic stressors, including exams and rounds, which made up the majority, call-related stress, stress in finding post-residency jobs and fellowships, as well as inadequate rest, so 4 or 5 hours of sleep per night. As a preamble to the remainder of the survey, just a quick definition of burnout. So burnout is defined as work-related syndrome characterized by an emotional exhaustion, depersonalization, reduced personal accomplishment, caused by prolonged and excessive stress. And depression, on the other hand, is slightly different. If we go back to our medical school days, it's characterized by markedly depressed mood or loss of interest, as well as a number of other signs, including weight changes and sleep changes, etc. In regards to residents that felt that they fit the criteria for depression or burnout, 56% felt that they did not. However, 38% felt that they did meet the criteria. And of those that did meet the criteria, 8% needed to take time off their clinical duties.
Sorry, I don't know how to get this to go back.
No problem, we can skip that slide, it's okay.
Okay.
In regards to components of resident wellness programs among residents who actually had a resident wellness program in their residency, mentorship programs made up the vast majority at 21.1%, as well as debriefing and support group sessions and self-care and mindfulness, meditation training, rounding out the top 3. This was slightly discrepant to what residents thought would be important as aspects to the resident wellness program. Number 1 being self-care, mindfulness and meditation training, and number 2 being screening for burnout or depression. In regards to aspects that resident programs use to promote wellness, this included social wellness, such as casual gatherings, professional wellness, such as mentorship pairs, or open dialogue forums about personal or work-related concerns, initiatives to improve rest, such as post-call days and frequency of call, among other initiatives as well, such as psychological wellness and physical wellness. In regards to stress, such as fatigue or burnout, adversely affecting a medical outcome, 16% of residents felt that this was the case. And 20% of residents who responded to our survey had accessed personal counseling services. And of those who did access these services, only 56% said they would access these services again. And those who did not access these personal counseling services, they did so because, number 1, they didn't feel there was a need, no time, or they thought it wouldn't be helpful. It was interesting to point out that there was about 10.9% who had the fear of lack of confidentiality and stigma, which prevented them from accessing these services. We'll round out our presentation with intimidation. So of the residents who did our survey, 42% felt that they had experienced some form of intimidation or aggression at work. And this stress was caused by attending physicians in about 42.5% of the cases, as well as patients in 23.3%. And 28% of residents felt concern for their safety when on call. And if there was a concern for safety, this was caused by an experience of physical assault by a patient, or fear of a physical assault, or verbal aggression by a patient. And in terms of structural changes, most residents felt that decreased demands on resident time, such as reduced morning and nighttime lectures or after-hour responsibilities, as well as providing additional time for wellness, were important. And our last question here, in regards to the Royal College of Physicians and Surgeons and COS making systemic changes to improve resident wellness, the number 1 thing was mandating the inclusion of a resident wellness program in ophthalmology training programs at 32.5%. In regards to take-home points, interesting facts from our study here was that 38% of residents met the criteria for depression or burnout. And major stresses were related to academic demands, call requirements, and uncertainty of post-residency jobs and fellowships. 42% of residents experienced some form of intimidation. And in regards to systemic changes, most residents agreed that the inclusion of a formal wellness curriculum in residency programs should be mandated. In terms of limitations, we had a 47% response rate. This was self-reported data, and there was more representation from larger programs. Thank you very much. And to conclude, I'll pick the school that will win. So I have the 4 schools in a bowl here. Unfortunately, my school didn't make the cut, but I have no conflict of interest in this. So I'll look away and I'll pick a piece of paper here.
So drum roll, please.
All right, what do we have here? Okay, we got UBC. Congratulations.
All right.
Congratulations to UBC. I had mixed feelings about this because I'd done my med school at UBC, but residency at McGill, so amazing job. Thank you guys so much for doing the survey, very detailed, and there's some good comments about you guys hopefully publishing it in a more formal setting so that people involved in resident training are aware of these results. So in the interest of time, we'll move on to Dr. Marc Hébert and Dr. Patrick Rochette. They are the president and the scientific director of the Eye Disease Foundation, and they will be presenting the Alain Rousseau Award.
So hello all. This evening, it is my great pleasure that as president of the Eye Disease Foundation, assisted by our scientific director, Dr. Patrick Rochette, to present the Alain P. Rousseau Award to a resident in ophthalmology.
Dr. Rousseau was an ophthalmologist and a professor emeritus at Laval University who was heavily involved in high-level research. 40 years ago, he felt the need to create this foundation in order to further support research in vision health. Today, the foundation has given more than $4 million in funding to researchers in Quebec.
The Alain P. Rousseau Award aims to honor his memory and also to encourage the development of ophthalmology research amongst ophthalmology residents across Canada who have completed research resulting in a higher level publication. The winner will receive a $1,000 scholarship and a distinctive plaque.
This year, the award is given to a resident who has distinguished herself in the most in terms of research. In 2019, the awardee has published in the British, the Canadian, and the American journals of ophthalmology and presented her work at the ONASRS.
Please join us in congratulating this year's awardee for the Alain P. Rousseau Award from the University of Toronto, Dr. Tina Felfeli.
Thank you very much to the foundation. It's an absolute honor to receive this award. Thank you so much to the COS and the panelists for organizing such an amazing and informative session. And lastly, I want to thank all my mentors at U of T who truly have a passion for helping their residents succeed. So thank you, everyone. And without further ado, I'll hand it back over to the panelists. Thanks again.
Thank you.
Thank you so much, Tina, and thanks for the presenters of the award. I actually had a chance to read about the Eye Disease Foundation dating back to 1979. So it has a very interesting history, and I encourage everybody to check it out as well. And thanks, Tina, for being a role model for a lot of the residents and upcoming medical students as well. So I think in the interest of time, we are gonna probably end there. I'd like to thank the COS and Dr. Dagger in particular for an amazing meeting. Cheryl Ripley, Rita, Cynthia, all the supporting tech team, and Dr. Satari is the eye who's been supporting us behind the scenes, and to my colleague Irfan, of course, for this session. So with that, we'd like to conclude, and I would thank all the speakers again. They were fantastic talks, and I encourage all the attendees to get in touch if you heard something that is of interest and follow up with one of the speakers. They are amazing mentors that you'll have for sure. And with that, I'd say thank you very much and have a good night.